Who's going to start?
I thought the way we divide this up, I'd talk for about 10 minutes, and I would just mention a little bit about the disease, the outbreak, both in Africa and here. I actually, in my earlier life, before I went into private practice in Morris County, I used to work for the Centers for Disease Control as a epidemic intelligence service officer, and I used to go out on outbreaks both in the United States and abroad, so it's sort of a personal interest of mine. We just got something in the last hour, and I was just looking at it just 5 minutes ago, so let me just give you, before I start talking about Ebola, just some of the new things that have come up. First of all, there are 5 airports in the United States which used to get 94% of all of the travelers from West Africa. But now the government has decided that since these are only the 5 airports that have screening, they're going to have all travelers travel through these airports. And if someone is identified who has fever or any other symptoms, now the Hospital Association is saying that there'll be 3 hospitals that they will go to in New Jersey. That's Robert Wood Johnson University Hospital and Hackensack Hospital. And the first 2 hospitals above them are those 4 hospitals in the NIH, Emory, Omaha, and Missoula, Montana, which are the super containment hospitals. But beyond that, we're going to have local hospitals that will be able to be specialized in caring for patients if we should have Ebola patients. So that really means that the hospitals in Morris County may need to only be prepared for the first couple of days until we get positive identification of a case, as opposed to being prepared for a long 2 or 3 week hospitalization. If they're low risk, apparently we're going to have a monitoring system in New Jersey where the state is going to follow these patients on a daily basis. If they don't report in, they're going to go after them and make sure that they're okay. If they're high risk, they're actually going to quarantine them in hotels that may be either abandoned or in hospitals which may have excess beds. So there's going to be sort of a quarantine if they don't have any symptoms, but we're concerned about them. I think the big issue here in New Jersey right now is seeing if we can get testing done on a timely basis. New York has set up a program where they're hoping to get 2 to 4 hour turnaround on the testing for Ebola. So if someone comes in, they can be tested quickly if they're high risk, and then they'll know right away whether they need to place them in one of their hospitals in New York. New Jersey is now looking at the testing for that themselves. It hasn't been confirmed yet, but that's what we're sort of looking at. If that could be done, then it may be just a matter of hours before we know whether we have a potential case or a real case. I just want to talk a little bit about Ebola because I know many of you are lay people who don't have medical backgrounds, and it's hard to get an accurate pitch when you're watching 24-hour news. But Ebola has actually been around since about 1976. All the outbreaks have all been in sub-Saharan Africa. But it's interesting that it doesn't sort of stay there all the time. Between 76 and 96, there were no outbreaks. And then 1996, they started having outbreaks again. And then every few years, they've been having outbreaks in different locations, not all in the same area either. And there's thought to be probably a reservoir in nature, some animal. Most of the countries that have had Ebola are countries which have a very high density of primates, chimpanzees and monkeys, etc. But those animals actually get sick and die of it, and we think there's probably an asymptomatic animal, probably a fruit bat, that is really spreading the disease. So it usually starts in rural areas, and usually it flares up, there's 50 cases or so, and then it just dies down because it's in a very remote area. But this time, it got into urban areas, and that's why it's so different. It got into those open urban areas where there are porous borders, and all of a sudden Liberia, Sierra Leone, and Guinea and West Africa had many cases. And then because of the health infrastructure in this area being so poor, most of the patients could not go to a hospital and be isolated, so they were cared for by family members at home. And that's been the multiplier effect, I think, of this outbreak, where they've the family members have gotten sick and taken care of their own sick members, and then it just keeps on multiplying from there. The current status is we have about 9,000 cases and about 4,500 deaths. So it's a pretty potent virus. About 50% or more of the people who get infected do die of the disease. You hear about this incubation period, 21 days. It appears that between contact with the virus and when you develop symptoms is anywhere from 2 to 21 days. And it's mostly between 8 and 10 days. So now, you know, the family was just released. Mr. Duncan, the one patient who died in Dallas, his family that was staying with him in an apartment for 3 days before going to the hospital when he was symptomatic, they have now been released from quarantine because they're beyond that 21 days. Transmission appears to be only very close contact. It's not, you know, just airborne walking through an airport terminal or sitting next to somebody on a plane. You actually have to have contact with some secretion, either vomitus or urine or stool or something. And that is why the healthcare workers are primarily at risk, because they're taking care of the sick patients. The symptoms early on are very nonspecific. Somebody doesn't come and you just talk to them for 2 minutes and say, oh, that's an obvious case of Ebola. Usually it presents much like a flu-like illness where you just have fever, a little bit of headache. You can have some nausea, vomiting, some diarrhea, muscle aches, but those could be the ordinary flu or the common cold or anything else. It's only when they get real sick in the second week of illness that they start having hemorrhage and organ failure to make you think really early on. So we're all taking the stance that if somebody comes from a very high-risk area like those 3 countries in West Africa, that we will regard them, even if they have very mild symptoms, as being a potential Ebola patient, protect our healthcare workers, and go from there. I must say that in terms of my feelings about this, the prior times when we've had outbreaks, like South Africa had a patient one time many years ago that presented at their airports who had Ebola. Senegal recently had one case and a traveler. Usually there's not much spread. Nigeria had 19 cases outside of their traveler who came into their capital who developed the disease. But they've now actually been declared free of Ebola because they've gone actually 42 days or twice the incubation period without another infection. So it is possible to contain if you isolate patients and you develop rings around them of people who are at low risk to high risk and make sure that they don't have contact with others. So that's basically what we've been trying to do at all of our hospitals. Is we've really been planning for several months now, ever since actually August, when they started having the outbreak, and it didn't seem like it was going to be just 100 patients or 50 patients. So we've been planning for quite some time now, and because 2 of the 5 hospitals that service most of the West Africans coming into the United States are in our area, JFK and Newark Airport, we anticipate that we will be seeing patients coming in. And remember, there's a lot of reasons to go to an emergency department besides Ebola. They come from areas which have a lot of infectious diseases, so malaria and typhoid and diarrheal disease, etc., are probably more common. In fact, I probably get 1 or 2 phone calls a day. I got one today again, but actually as a person who's been to Haiti, which is an awful long way from West Africa. You know, West Africa is not one country. There's 34 countries in Africa, and if you don't come from one of those 3 countries, you're really not at risk of coming in with Ebola at this time. So our main goals are really not to miss a patient. We're trying to learn from what happened in Dallas. And if you remember what happened in Dallas, someone came to the emergency room, was sent home with a fever, and the information was not transmitted that he had come from one of the high-risk countries. So we want to make sure that that doesn't occur at any of our hospitals. So we have signs up everywhere. If you've traveled to these places, tell us. Also, it's part of our routine screen of questioning. And then if they do make the screen, that is, they have symptoms, and they've been to West Africa in the last 21 days, they've been put in isolation rooms, and we'll begin the evaluation. So those are, and the other thing, of course, is protecting our employees. You might imagine that at all our hospitals, everyone's very concerned after those 2 nurses in Dallas got infected. So we're really taking extraordinary measures to try to make sure that all of our employees are safe. I think I'll stop there because I think I probably have talked for 10 minutes or so, and I'll let Dr. Radcliffe continue. Okay.
Great review.
Yeah, actually you covered most of it. The only thing that I would add is that at St. Clare's, the addition of the 2 screening questions once it's positive we isolate, and we do have a team that we're gonna call in, because to educate and train our staff, especially the donning and the doffing of the personal protective equipment, is so laborious that we decided that we're going to have a special team. And they're the ones who's gonna practice day in and day out an identification of those certain key people. And we are going to do that. We've also trained our patient access people when they come in, our security and the emergency department as a whole. But once we isolate them and the management and care of those patients, it will be done by a special group of people who we are going to, again, as I say, really do specialized training in the donning and doffing. I mean, we are going to be managing and taking care of those patients. We are knowledgeable in that. We'll be guided by the infectious disease consultants, Dr. Allegra, and we have another one, Dr. McManus. This special teams will be in 2 shifts, so we actually will have 2 teams, Team A and Team B, and they will mirror each other and be able to take care of those patients. That was yesterday. Today, when we heard that they're going to be transferred to those 3 hospitals, we still have to take care if they're suspected or rule out Ebola. We will still do the things, and we hope that once the test comes from the state or CDC, depending on whether the state will be up to speed on testing that in a timely manner, then we will transfer those patients in the 3 hospitals that were identified here in New Jersey. So right now what we really are concerned is really the training of our staff, and we have put an education, a video, and a PowerPoint presentation, actual people. We've put a body system, just like what they told us, that somebody will be a body to that person so that they can don and doff the personal protective equipment with somebody watching. Not only somebody watching, but also a body that will tell them what to do. Because when you're in that situation, you either are doing it hurriedly or miss a step. So someone will be monitoring that, plus their body will be helping them don and doff off those equipment. That's to protect our employees. So I know we've talked more than we should, but if there are any questions whatsoever, we're here to answer those.
Yes, and another great review, and talk as much as you like. The more the public knows, and the more secure they feel, is great.
Would you like to add to anything that I just said?
Well, actually everything was covered, but we are actually revising also our educational programs, because as we know, this information changes on a daily basis. So we can kind of update our educational programs to our staff, because like everybody else, they have a lot of questions also, how they can protect themselves and everything like that. So we are trying to keep up with the information we're getting from CDC, the Department of Health, the New Jersey Hospital Association, and trying to make sense of those information so that our staff in general can understand it. It's just too many information out there.
Yeah, so what we've done to that is every day at 4 o'clock in the afternoon, we have a teleconference, and everybody calls in, those who are interested, but mostly we require the management of St. Clare's to call in at 4 o'clock. We provide them with all the current information that's provided to us by CDC, the New Jersey Hospital Association, the New Jersey Department of Health. We put that together and we share that information every day at 4 o'clock. And if the managers then are required to tell their staff, we don't want anyone at St. Clare's to basically say we don't know what's happening. So that's the reason why we set that up and put that in place. So we just started our 4 o'clock calls, and it went very well, because prior to that call, we received the new information regarding what Dr. Allegra just said about the quarantine and the 3 hospitals, and we're able to quickly share that with our employees.
And to date, what we have done so far, we have done a couple of drills already. We have done one that was mandated by, or required, or recommended by the state. And also we did a drill also this morning just to find out how our specific departments, how they are handling when a patient walks into the door, either in the lobby or in the emergency room. So we found a lot of opportunities still, because we are still in the process of learning all of this. But it's a good drill.
So I'm not going to review many of the things that were said, and there's been a lot of coordination, not only within our health system, Atlantic Health and Morristown and Newton, Chilton, and Overlook, but also there's been a lot of discussion between hospitals as well. The three areas that I think we can summarize concerns, if you will, are: one is, how do we protect the patient, and how do we treat the patient carefully? Two is, how do we protect the staff at the hospitals, which I think has been covered here significantly. And more importantly, how do we protect everybody else in the hospital should, some patient come in? I know that at all of, certainly at all of our hospitals, and I presume at just about every other hospital, isolation areas are set up for containment. We've constructed specialized showers so people can get cleaned off and eliminate all the infectious issues. But the one thing that I do want to stress, which Dr. Allegra mentioned at the beginning of his talk, is that of any of the people that have gotten infected now worldwide, including any of the healthcare workers in this country, the healthcare workers in Spain, and the family members and people that are getting infected even daily now in the countries in West Africa, is that the route of transmission is still direct contact with bodily fluids, whether it's bloody diarrhea, whether it's bloody vomitus. It is not an airborne disease. People don't get it from, if somebody came into this room and even had symptomatic Ebola, as long as they didn't have explosive diarrhea and explosive vomiting, they are, while they are infectious, potentially, they go home and you contact their body fluids, they're infectious. But walking into the room, meeting them on the subway, people who have Ebola, it is not airborne. It is not contact. If you go back to Dallas, the only people in Dallas that were contaminated were 2 hospital workers. All of the people that lived with this man for days unprotected while he was ill, and while he was excreting sweat, while he probably had some diarrhea in his home, they did not have contact, they were not infected. The first responders that went out to his apartment were completely unprotected. None of those got ill. So again, this is not a casual thing. Influenza is spread much more easily than is Ebola. As far as help, and I don't know if you want me to take 2 more minutes just to go in on what's coming down the pike as far as treatments, because there are some treatments. None are approved yet. I think ZMapp actually might have gotten some level of approval from the World Health Organization, although it's not been approved by the FDA. There are a number of treatments that are being developed. There are a number of vaccines that are being developed. There are those that are using different viruses to carry in some of the cloned genes from Ebola so that we can make antibodies to these. One was used to protect a laboratory worker who was self-injected, unfortunately, with some Ebola that was being used in that lab. Whether or not they would have developed disease is unknown, but certainly they did develop disease, and that vaccine was used actually not as a protective, as a prophylactic, but actually as a therapeutic measure. There are other vaccines that are in development, some that are initially set up for prophylactic measures, and adding some aspects to it, it may actually be a therapeutic, being able to treat people even after they've started to develop symptoms, 6-7 days later. There's a couple of compounds, certainly, that are useful in early disease. There's one that actually block the replication, block the ability of the virus to make more of its own DNA. And there's a few of those. And then the ZMapp, which is a conglomeration of different antibodies that are now made in tobacco plants. They actually clone the antibody genes, put them in tobacco plants, and let the tobacco plants make these humanized antibodies. So there is a lot of work being done. The clinical trials that are being run by DARPA, NIAID, the USAMRIID, a number of the company, and many of the companies, those clinical trials are undergoing. There are more that are starting within the next months, and so there should be a number of products out, certainly within the by the spring. But between now and the spring, we obviously have, containment is really the key. Containment and keep the fear in reality. Because unfortunately, if we go at this without some measure of forethought, then we do things wrong. And so going at it calmly, protecting both our staff, protecting the public, and obviously protecting other patients, but more importantly, we do need to care for the patients that do come in.
Okay, Doc. Well, thank you very much. Scott, would you like to?
Yeah, and just because I know that Carol's filming, maybe it would be better if I start from here, because I have both Jeff and Carlos to speak to, and so you don't have to move the camera too much. I guess for me, I'm lucky enough that within my department, 4 of my divisions have some handle or some interaction related to this Ebola, from our health department, our communications center, the medical examiner, and what we've been doing with OEM. So we've had some conversations with the hospitals last week. We did a few conference calls because we have been really serving as the focus from Carlos's end into the health departments, and Jeff has been communicating frequently with the first aid squads and law enforcement to give them information. I'll let them speak about their specifics, but to make sure that we have a comprehensive plan. And I want to reiterate, for our purposes that we're spending the time preparing is because we're concerned about the one-off potential case for the emergency responders. Not the general public, it's not the SARS, it's not any of that, but we're concerned about that one case that may happen that the first aid squad goes to and nobody questions. So for the other 2 divisions, from the communication center for the towns that we dispatch for, we actually implemented a new call query protocol that addresses those key flag questions on a 911 call, and the computer system actually flags that as a potentially emerging infectious disease, and that information is relayed to the police officers, the first aid squads, and we set up a protocol with them of how they would be notified and how they can get information. We had a conference call with the police chiefs, I think last Friday, if I recall right, but last week, 1 conference call with them before we implemented it, 1 conference call, or 2 conference calls with EMS to explain that to them. Ironically, we finished up the call with the EMS squads about how we relay the information to them. We're asking the questions. We finished up the call. We were still in the office. With 10 minutes later, the communications floor called up and said, we just took the call query and we have the red flags for a potential case. It was a front desk clerk, which I think we're going to start getting these calls, not the person calling, but it was a front desk clerk of a hotel that said there was a person staying there that is a pilot from Africa, and they've been coming back and forth to the front desk looking for cold medication because their nose was running, their eyes were running, and the person now left to go to the pharmacy. So we actually sent that communication out through our mobile data terminal so it didn't go over the air, and the police officer came back with, "Are you kidding me?" And the first aid squad came back with, "Is this a drill?" But we ramped it up. They called for some help from us. Carlos is actually a health officer there, and the police went through. We notified the hospital. Morristown was going to be the receiving hospital. We made those notifications to them so everybody was prepared. It turned out it was a person who had a toothache, but it took 2 hours to find the person to get them in there. So we will get those calls. From the medical examiner's office, we've been looking at from what we can do to prepare for that. We actually participated in a call with all the medical examiners, including New York City and Long Island, to talk about a comprehensive plan and how they can assist each other for people that have or don't have the right equipment. So we're making those steps. from my department, our job is really to be prepared, whether or not statistically we're gonna have a problem in Morris County. Ours is to make sure that we're ready if we do, and that care and that communication follows from that first responder all the way to the hospital, so nobody gets surprised. So let me just spend a few minutes, Carlos, I'll let you talk a little bit about what you're doing and some of the information that came out today, and then Jeff can speak a little bit about what we're doing to help the municipalities with some of these issues.
Health management, I can speak on that.
Yep.
We've actually been monitoring this situation closely. We've been in communication with the State Health Department routinely as questions come up. We try to obtain information mostly from our local health officers in terms of guidance, and we've had a pretty much a conference call every other day with the State Health Department. Our Office of Health Management webpage is continually updated with information and resources, not only for our local health departments, but also for our residents. As critical information comes across from state health, we disseminate that information not only to our local health departments, local health officers, but our public health partners. So just talking points, information on PPE, and just public education. We have an advantage here in Morris County in that we developed a quarantine and isolation plan. We started developing that plan last year, and we collaborated with the Northwest Public Health Region, which is essentially Morris, Warren, Passaic, and Sussex counties. So we developed a plan that provides step-by-step guidance and templates, affidavits, and court orders that health officers can use to quarantine and isolate individuals if needed. And this plan is actually, was mentioned during the state conference call today, State Health Department conference call as a model. And we received, I'd say about 20 to 30 calls from local health officers throughout the state requesting our plan. So we're sort of at the forefront on that end. We've also provided model ordinances for our local health officers. That model ordinance that was established that allows health officers to bypass the court order procedure if they have an emergency and need to isolate and quarantine an individual. Essentially, we are going to have a conference call tomorrow with our local health officers that cover our 39 municipalities, and give them information on, kind of give them a refresher course on the isolation and quarantine procedures to follow.
Okay, thank you. Scott? Yep.
Good evening. We're working with our response partners, as Scott mentioned. In fact, we're training tomorrow on our PPE protocols and donning and adopting, as was mentioned earlier. One of the things that we're doing at a county level, we're working cooperatively within a department between health, hazmat, emergency management, and a decon system, where we're going to have, we already put a response group together and a response vehicle together with all the necessary PPE related products that might need to be supported locally in the event that a call was triaged by health to indicate that they had a suspected case. What we're encouraging the local EMS to do locally is to marry up with health to make sure that they have a local response protocol that meets the guidelines with local health. And that's really important for EMS to make sure that they are marrying up with health, so these calls are triaged to the point where health is involved in looking at these red flags, and even to the point where, if necessary, as we did in the case that was referenced, where we put health in contact with local police to talk to them about some of the additional drill down questions that need to happen. The fear that we have is that we will have, some, overreaction to what, as we progress into flu season, that everybody's going to have Ebola. We don't want to, rise to that level. So we're really trying to make sure health is on board locally in every municipality with EMS, so these calls can get triaged, even to the point where we know there's going to be cases EMS is going to enter into a facility with maybe no data to suggest there's an issue, and then all of a sudden they feel that they may have been compromised. We're still going to drill that down with health at that point to see if there's any red flags that need to be of a concern. In the event that a local municipality has an issue on a response that they feel that they can't handle, meaning that they either don't have appropriate PPE protection or they're not comfortable that they can go into that environment, then that's where we will come in for the higher level of calls with a trained group, and we will go and support that process. So we're doing a lot, the information as mentioned is changing every day. We're looking at, spending a lot of time on this topic. A lot of our EMS agencies are trying to get PPE protection. A lot of it, as you can imagine, is on back order, so there's some issues with that. So we're going to be making ourselves available with the equipment that we do have in stock at the current time, and we'll be refining the process as we go based on the protocols. We're working very closely with the hospitals and the emergency management process within those hospitals, and we've had nothing but cooperation from health to the hospitals and everybody in between. So we have a good program here in Morris, ready to go.
Okay, great, Jeff. Thank you so much. Thank you, Scott. Any questions? Okay. I'd like to thank our healthcare professionals from St. Clare's and from Morris Town Memorial. I do want to add that I spoke with the administrator and the freeholders that we're going to set aside $25,000 in a special fund for whatever towards this event, if there's an event, to assist you guys between now and the end of the year, this budget year, and then we'll take it from there. Hopefully, we don't have to look at it in January.
Thank you.
So thank you.
Thank you.
Thank you very much.